Welcome everyone to this short presentation for people who are interested in getting to know more about non-invasive ventilation, especially for patients with motor neuron diseases. I've actually presented this a couple of months ago, and this is the second time that this presentation will be repeated, as it was believed to be important to create awareness among either caretakers or family who cares for patients with MND. So this is where I work at the moment. It's University of Malaya Medical Center, and if you can see, it's quite near to the Kuala Lumpur Metropolitan City Center. Do drop by if you're from other areas of Malaysia or even out of Malaysia. If after the COVID-19 pandemic, if you plan to pay us a visit, you're always welcome. So the content of the talk today, I'm going to put it very simple into a few parts. We're going to start off with ALS and what are the symptoms briefly. I'm sure that has been explained very thorough by Prof. Notina in one of the lectures also a few months ago. And we're going to go into NIV. What's the usage of NIV? How does it help? We're going to go on to some basic steps to initiate and what are the complications that we should look out for when patients are on NIV, and what are the solutions to regards to any complications that arise. And last but not least, one or two slides on telemonitoring. So ALS is a progressive neurological disease of unknown cause, because there is this degeneration of your motor neurons, commonly seen in around 60 years old. It has male predominance, and from the literature itself, median survival of this condition is roughly around 3 years. So majority of the patients with ALS actually they will not do well because of the respiratory failure as a result of the weaknesses of the respiratory muscle. And in the past, because of that, a lot of physicians or families or patients look at it that with ALS itself, it is a form of prolonging suffering and death. But with the introduction of non-invasive ventilation to help in respiratory function, it has shown NIV can actually improve survival and quality of life for this group of patients. And when patients have ALS, a lot of times when they come to us, the main complaint is either limb weakness or bulbar symptoms. And very few, or probably less than 20%, is actually aware of their respiratory symptoms. So it is important for everyone to take note when the patient is breathless, either with or without exertion, it signifies a late feature. So what are the symptoms that has been under-recognized such as like patients feeling breathless when they lie flat, or sometimes they do have sleep-related symptoms. All these are early symptoms. For instance, when the patient wakes up in the morning, the feeling of unfreshness, feeling lethargy, feeling fatigue, feeling disturbed quality of sleep. So all these are sleep-related symptoms that can be early features in patients with ALS. And when doctors examine these patients at the early stage, there will not be any physical findings. But at a later stage, they may have weaknesses of the muscle group, they may have weak cough, and on a more severe stage, they can be seen using their accessory muscles as in like some of the neck muscles here. Sometimes the abdomen itself, what we call, may move paradoxical, meaning that if you look at the diagram here, compared to a normal subject, when the patient breathes in, the tummy actually draws inwards for patients with advanced ALS with respiratory issues. So for respiratory physician like me, the main thing that we are always very concerned is the respiratory muscle weakness because of the diaphragm. There is also a concern on the bulbar muscles, that means the muscles that is involved in swallowing or phonation, and also protection of the airway. And because there is a weakness in the lung function itself, where the patient is unable to take in enough volume of air, the cough is also weak because the inspiratory muscles and expiratory muscles are all affected. And the last one that you can see in the black box is sleep-related symptoms. That means sometimes patients may have complex sleep disorders, which will not be presented today. So for me, the focus is more on the muscle strength and the lung function. So when ALS patient that is being evaluated in the clinic, objective measurement is measurement of the lung function, and it has been documented that for ALS patient, estimated 3.5% of the vital capacity, that means the volume of the lung decline each month. And there are mainly a few methods to measure the lung function, either the volume, which is the vital capacity, or the muscle strength, which is the inspiratory pressure. You can see there is two ways, whether it's inspiratory pressure measured through the mouth or through sniffing through the nose. And both methods are actually acceptable. During the early stage, measurement of the respiratory muscles are more sensitive compared to measuring the volume of the lung. So all this measurement will be advised or will be carried out by your doctors who see you in the clinic. Now, apart from weakness of your respiratory muscles, something that I want to bring your attention to is called hypoventilation. So the term itself is self-explanatory. That means the shallow breathing. And when imagine by logical thinking, when your muscles are weak, especially at night when our body goes into deep sleep, the muscles are depending on signals sent from the brain to continue to breathe. And when these muscles are at the weaker side, especially the diaphragm itself, it can actually cause shallow breathing. From there, a shallow breathing can actually lead to low oxygenation and increase in carbon dioxide levels because the gas exchange is affected. So like I've mentioned earlier on, some of the symptoms may be feeling tired, feeling sleepy in the day, out of breath. Those are the symptoms. So when a patient has hypoventilation, some effects from it is it can stimulate various effects in other systems like the hormonal systems. It can actually cause deranged sugar levels because of these hormonal disturbances. Neuronal disturbances whereby because of hypoventilation, and in a simple explanation, the heart needs to work harder, so it stimulates the heart to beat faster. So that's what we call a neuronal stimulation, a sympathetic stimulation. Vascular itself, it can cause narrowing of the vessels, leading to a condition called pulmonary hypertension. That means the pressures in the vessels build up. And all this is some unwanted effects of hypoventilation that if it's not being addressed, it can cause a lot of complications, so on and so forth. So one of the ways to address this hypoventilation, this breathing weaknesses in breathing or ventilation is through non-invasive ventilation. Over the years, there's many evidence that shown that NIV helps in patients with ALS. So the effect is by helping in the ventilation, it has an unloading effect so that the CO2 levels would not climb up. It increases the ventilatory stimulus, especially during the day. Patient will feel improvement in their symptoms, and it has been shown to improve in the lung compliance, means that how a lung actually works. Okay, the certain group of patients of ALS without bulbar dysfunction, it has been demonstrated NIV helps in survival benefits and quality of life as well. And one study also demonstrated patients on NIV has improved in cognitive function. And another paper shows that it slows the decline in lung function. So the best time or the optimal time to commence NIV basically depends on three things for doctors who assess patients with ALS. For caretakers and family or even patient itself, so it is important to recognize the symptoms that I've mentioned earlier on. So number one, okay. Then when your visit to the doctor at the clinic, the doctor will assess you objectively or subjectively. Subjectively means by asking you the symptoms again. Objectively, it's measurement of blood gases. Blood gases is the blood that is being withdrawn from your small vessels to check the carbon dioxide levels. And your doctor will also evaluate the lung function in terms of your lung volume and muscle strength. So let's go into non-invasive ventilation, what exactly this is. In the good old days where it all started during the polio pandemic, when patients with polio experience respiratory issues. That means the muscles are the muscles are attacked and involved, and subsequently patients are having problems with ventilation. So they will, and that was the time where ventilation was created to assist in breathing for this group of patients. So the initial part is, you can see from these diagrams here, the patients are being put in something called iron lung to help them to breathe. Over the years, this iron lung has gone through an evolution until the development of what we call a positive pressure ventilation. That means your ventilation is positively provided into your lungs by the device or by the mask or the circuit itself. The device itself is a ventilator, we call it. Okay, it's a device. That means it helps you to breathe, and it's not a device that supplies oxygen. So this is extremely important to understand. In the market itself, as you can see from the pictures shown, you have basic models on the left side. You have higher end models, which is on the right side. The difference between them is difference in the mode of ventilation, which your physician will explain if you really need something more complicated. Also difference in terms of internal battery. All device can be driven by a blower or turbine. Okay, on the right side, the higher end machines can actually run throughout the day because they are more long lasting. And otherwise, any of this device, if it is required to blend in oxygen, you are able to do so. I think in terms of ventilation, there are one or two small things that we should be aware of. Although this is a little bit technical, allow me to just provide some explanation so that you get a little bit of idea what ventilation is. Yeah. So in order to provide breathing, you need a trigger. Okay, trigger means at the beginning of inspiration. As you can see here, if there's a trigger, there's increase in the pressure and the flow. And once this inspiratory cycle ends, okay, that's the limit, it will cycle off. It will cycle off, that means the expiration, that means breathing out occurs, so that the next cycle of ventilation can occur again. And from the NIVs that used for patients with ALS, there are different modes available. First of all, there is something called a spontaneous mode. That means the breathing of the patient, the inspiratory pressure solely is patient-based. That means patient initiate the trigger and initiate the breath, and patient cycle off the breath. Whereas if there is assisted breath, that means the breath is initiated by the patient, but the cycle is by the ventilator. A time breath is another mode it's hardly used because both the time and the cycle is all machine determined. Some of these useful ventilator parameters that you may want to take note because it's can be seen on the device screen. Sometimes if you are aware there's a parameter on the device screen that's called VTE. This is the estimated volume. That means the volume of air on each breath. There's another there's another thing that is called minute ventilation. That means total amount of air when the patient breathes in and out for 1 minute. And minute ventilation is equivalent to your tidal volume multiplies by your respiratory rate. That means how many numbers of breath per minute. Then you have something called a peak inspiratory pressure. It's also on the monitor itself, which means that the highest pressure in the chest and in the circuit. So the important thing is the first three, the tidal volume, the minute ventilation, and the respiratory rate. So normally, once you're at home, a rough eyeballing that the patient is doing fine is to look at this. If you're aware of, familiarized with these parameters, is to look at these three parameters on a normal day or even that when patients are unwell. In terms of circuit, there are many types of circuit. There's dual limb, there's single limb. Single limb, you have a passive and active circuit. We're going to make things simple and concentrate on a single limb passive exhalation valve circuit. So this is the circuit that we commonly use. Just concentrate on the right side. So meaning that there's only a circuit, right, from the ventilator. And this circuit itself is vented. Vented means that there is a port or there is a valve for exhalation. So it can be in the mask itself, it can be at the circuit, okay? And if it's at the circuit, there are various ports that is shown, like the viscous fuel, the plateau valve, all these are the exhalation ports. So it is important for family members or caretakers to remember not to treat this port as a leakage. And in the past I've come across like some caretakers that's not brief. They will alarm that there's a leakage in the circuit and they try to tape it with some cellophane tape or something to just to close up the leakage, not knowing that this is actually an exhalation valve, right? So this is where we call a vented circuit. Okay, this is the commonly used that we apply to our patients. So after the device and after the circuit, we come to a mask, or we call it interface. Yeah, interface is a more common, more formal term. Is there one mask that is the best, and how do we decide what sort of mask to use? And I would really need to emphasize in terms of, from my years of experience that I've using non-invasive ventilation, I would say the mask is one of the most important gadget that we should look into. It's actually not so much on the ventilator, it's the mask. Because imagine if the mask is not comfortable, definitely the patient itself would not feel comfortable wearing it. It will affect the usage, it will affect the compliance. So some of the concerns are whether the mask is leaking, whether the mask is delivering enough volume to the patient. And sometimes if the mask is too tight or the size is wrong, it can cause a lot of issues like discomforts, pressure sores, intolerance. So we need to constantly remind ourselves to sort out this mask, or else it will actually cause a lot of problems later on. Okay, this is a picture just to show various types of masks available in the market. These are, if you follow my arrow, these are some new masks available. This is the pillow. This is a new full face. That means it covers your nose and the mouth. This is the conventional type. And this is the nasal mask. That means it covers the nose. So this is, you can see this new full face mask. There are some vented areas here for exhalation. Nasal mask over on the left side, and this is nasal pillow and nasal under the nose. So there are many types of masks, and the concept that is really important for us to understand is there is no one best mask, because each each person actually has different uh, face face figures. So the best is actually to do a proper mask fitting to see which mask suits the curvature of the face or the mouth or the nose best, and that will be the best mask. There's a paper that has been published a few years ago to demonstrate between all the masks that you can see up here, the efficacy in providing ventilation is similar throughout all the masks. But there are some exceptional during the use of masks. For instance, that if someone has issues with the nose, like the nasal patency is affected, then you would not want to use a nasal mask because it blocks the ventilation. And if someone who has got a lot of secretions, bowel issues, who would like to cough and remove the secretions, then it will be better just to use a nasal mask rather than a full face mask. Someone who doesn't want pressure over here, then there are other alternatives. For instance, like mouthpiece ventilation, nasal prongs. Someone who prefers to speak, then it would be better to use a nasal mask than the total face mask or the oral nasal mask. So apart from looking at different sizes, the other things to look at is whether the patient is claustrophobic as well, because the oral nasal mask could be too big and may not be comfortable for most patients. Mouth breathers, some patients actually fully dependent on the mouth during breathing. And if you provide them a nasal mask, they can actually have a lot of leakage. Sleeping position is one, because sometimes if your mask is too bulky, during different sleeping position, it can slip off and it can cause a lot of leakage. Facial habitus, as I mentioned earlier on, okay, sometimes beard is another issue. By providing an oral nasal mask, sometimes the beard can affect the sealing of the mask, so causes a lot of leakage. And the type of masks, for instance, like silicone, which is lighter, gel conventionally is heavier, but it's longer lasting and it's more comfortable. So it depends. These masks have to be tested out before prescribing. Your home care provider, before deciding on the mask, they have different guides as shown here, guides or gauge to measure the size of mask that fits you. And this is just some parts of a CPAP mask that you can find. I don't think it's important to memorize all this, but this one gauge here that is commonly applied to decide the size that your home care provider will use. So some tips of mask fitting that I find useful, I've listed here is, first of all, use the smaller size, then not to over tighten it. And the adjustment can always done at the headgear. Headgear means that it's over here sometimes, and sometimes it's a strap as well. So it's important to know that the cushion or the mask should not be crushed against the face. So after, when you tighten it, make sure the cushion is not pressing against the skin. As I mentioned earlier on, exhalation port is extremely important, not to be blocked or to closed up. We normally try to divert or direct the exhalation port away from the patient or the partner. We normally do mask fitting starting with the erect position, and after patient is comfortable, we do it at lying down to get them adapted to it. Once the mask fitting has been done and the patient is comfortable with it, sometimes we can provide a marker at the headgear strap, so that every time the strap comes on, the caretaker knows that which is the correct location to apply it back. Removing of the mask can be done through a quick release clip. Some of the masks have a quick release clip. Always remember to fit your mask before strap on, not strap on and fit the mask. Okay, so for instance, like you take the mask and put it nicely before you strap on. Okay, A leak test is something that some of us apply as well. That means once the mask is fitted nicely, you can actually rotate or tilt your head at different directions to see is there any leak. For instance, you can tilt your head up, tilt your head down, left or right. Okay. So example, if you tilt your head to the right and there's a bit of leakage coming out here, then you probably would like to tighten the strap on the left side a little bit more. So these are the various steps. As you can see, like my cursor here, fit the mask before you strapped on. Okay, and it's similar with other types of masks as well from these diagrams as shown here. The following diagram here is not really a single limb, it's a double limb circuit. And I just want to take this opportunity to show the importance of some of the patients may be on a tracheostomy ventilation. So sometimes when a tracheostomy ventilation, it's connected to something we call active humidification. So this is the device that humidify the air so that the air that goes into the throat will not be too dry. And the alarm itself, sometimes you do have different types of alarm. We're not going to go in through it detail for today because we are talking about non-invasive ventilation. So yeah, we're going to just skip this slide. In terms of stages of initiation that I normally do, first of all, we start off with stage 1. That means it's important to explore patients and caretakers' view. What do they think about non-invasive ventilation? Explore the level of social support as well, because sometimes apart from caretaker, apart from the patients, the family, or anyone that is taking care of the patient, it's important to roughly know what the patient's needs, roughly know what the NIV does for the patient. Some other things that may influence the adherence, that means the compliance, is nutritional status, weakness of limbs. For instance, like if your patient's hands are weak, definitely it can affect the patient wearing the mask by himself. So it's important for the caretaker to provide assistance. Bulbar function is one. So for certain ALS patient who has got bulbar function dysfunction, certain masks may not be ideal, and certain settings of the machine may vary. And cognitive function is as well, because patients who are unable to cooperate may not tolerate well for NIV. So this NIV stages, I've actually went through it, so I'm not going to go into detail. Stage 3, so normally initiation of NIV, I'll start with very low pressures. After strapping them on, you can start with IPAP of 8, EPAP of 4. This will be done by the home care providers. As they are undergoing an adaptation process, we build confidence. We will ask them, will you, are you feeling fine? How's your breathing? How's your exhalation? So on and so forth. Is the air too dry? Are you synchronizing well with the machine? So a lot of questions will be asked to build confidence and also to bring the patients coming together with the NIV itself. Okay, address to concerns they may have. They may find suffocating on the mask. They may find that the mask is too small, too tight. So all these things we normally do as we adapt the patients to NIV. So the things that I mentioned, the concerns has been listed out on the right side. Yeah. Okay. So complications and solution. I've listed some of these very common complications. Airleaks. So airleaks can be intentional or unintentional. As I mentioned earlier on, intentional is where for exhalation to clear off your CO2. For these unintentional leaks, sometimes it can, that means either the leakage in the circuit, or let's say the mask is not fitted properly, it can cause a lot of consequences, such as it's going to be noisy, it can cause disturbed sleep, It can cause eye irritation as well. Imagine the air is blowing through, leaking out and blowing through at the eyes the whole night. And not just symptoms, it can cause ineffective ventilation. So a lot of this NIV, because it's based on pressures. So imagine if there's a leakage, right? It's pressure triggered. If there's a leakage, then the machine will keep providing volume, causing a lot of dyssynchrony as well. We call it triggering and dyssynchrony to the patients. So some solutions for leakage is you can apply, depends on where the leakage comes from. You can readjust the mask again, check for leak, and if the leak is coming out from the mouth, you can apply chin straps. Ensure that beards and dentures are not the one that's actually causing the leakage. And there are some pads like this, foam pads that you can apply if the leakage is coming out from the nasal bridge. Now, this is to show some of the real cases that I've managed before. Initially, may not be apparent, but as the patient is wearing, you can see the leakage is coming out from the bottom, where the mask is too small. It's the lower lid is coming off from the mask. Okay, you can see over the bottom here, and this picture on the right shows that the leakage is because of the beard that is affecting the good seal between the mask and the skin. And this is one way that you can see leakage as well during the mask. Okay. So I'm not sure whether you can hear, but towards when the patient tipped the head down, you can see this. You can hear there is hissing sound coming out from the bottom, because the mask is too big for this patient.
你喐下口睇，OK， 冇少少唔好睇多，喐下。
So again, like I mentioned, not one mask fits everybody. Depends on individual itself, and full face mask may not be the best because some studies have shown that it increases risk of aspiration. It can actually. It causes a lot of aerophagia. Aerophagia means that the tummy is filled with air, and it causes a lot of pressure sores because it covers the mouth and the nose, and it limits the ability of the patient to communicate. And some of the tips to enhance the adherence to your mask, like I mentioned, try on different types of masks, okay? The tubing itself, if your patient is not comfortable, sometimes the tubing can be put at the back. You can actually elevate the tubing so that it will not disturb the patient deep in the bed. One thing that I find is helpful is I think nowadays most of the NIV comes with humidifier. So humidity itself can improve compliance. If the patient has any nasal blockage, nasal spray, nasal steroids may help, and adaptation may help as well. Okay, what do we do if the patient experience pressure sores? Just for instance, like all these pictures that we can see. Again, readjust the mask, not to over tighten the mask, the straps, okay? And always constantly monitor all the pressure points. If your patient is able to adapt to two types of masks, you can do a mask rotation. The third picture here is you can see this patient develop some form of rash from the material of the mask, okay? The fourth picture here is a way that roughly to check the tightness of the strap, okay? You should be able to include 2 fingers in between the strap. As I mentioned, aerophagia is feeling stomach bloated because of using an NIV. Some patients may tell that they feel nauseated. Some may have actually reflux symptoms after using NIV. So some solutions that has been shared is to try out, you can try out this, I think the ResMed machines have this function called expiratory relief pressure. Can try to reduce the mean pressure a little bit with the help of your physician. You try to reduce a nasal mask. And one way that I tried quite frequently, and I find it's effective, is elevate the bed. Yeah, elevate the bed. It can actually help. Some patients, some physicians will prescribe medications like antacids. It can also help. Dryness and irritation is a very common issue that we face, especially imagine that because the nose itself is an organ that humidifies air. So imagine sometimes the air that comes from the machine is cold and is fast. It can actually trigger a lot of mucus production. From the mucus production, it can actually blocks up your nostrils. So one of the few solutions is try to adjust the humidifier and the temperature, ensure that the air is not too dry and the air is not too cold. Sometimes you can apply things like nasal steroids, sprays, decongestion, that may help as well. Yeah. Last but not least, we're going to go into one or two slides on telemonitoring. This is something rather new over this part of the world. Nowadays, your progress or your NIV use can be monitored through the cloud software. All the brands of NIV has this function, not to worry. Okay, and as you can see, this is a picture of me. Sometimes we monitor on the left side. This is a mask fitting done by the home care provider, and I'm monitoring the mask fitting, so to ensure that they are comfortable. On the picture that you can see on the right side is the waveform, the sleep waveform of the patient. So sometimes after the results are out, if I have any doubts, this waveform all can be monitored online. The bottom part, you can see I do communicate with my patients to get their feedback, how's their usage every night. And sometimes their family can even take photos to show if they do have some bizarre sleep pattern. Okay, so these are the photos that they show overnight. And that is my last slide.